Hello everyone, today we're going to continue with our studies of the knee and the femur. In part A, we talked about the lower leg, the AP and lateral. We talked about the knee, the AP and the lateral, and standing knees. Today we're going to continue with the knee, and then we're going to finish up with the femur as well. So we're going to talk first about the obliques of the knee. So the AP oblique of the knee with lateral rotation, the patient position is supine. You may have to elevate the unaffected hip to actually rotate the affected limb. Remember, we're not just turning the foot, we're actually rotating the entire knee. So we have to, many times, actually elevate the unaffected hip. The knee is extended, the limb is externally rotated 45 degrees, and your central ray will be to the middle of the knee, 1/2 inch below the patellar apex. Now the central ray is going to be a little bit variable, and once again, this is a little bit different than what you're going to see in clinical. According to Merrill's, you have to measure the ASIS to tabletop measurement with a caliper. Once again, those are not easy to find in departments today. You do have to know this information, though, for the registry. And that measurement, if it's below 19 centimeters, you're going to angle 3 to 5 degrees caudad, 19 to 24 centimeters perpendicular beam, and greater than 24 centimeters, 3 to 5 degrees cephalad. And once again, you're going to be entering 1/2 inch below the patellar apex. As far as medial rotation of the knee is concerned, patient is supine. Elevate affected hip if necessary to rotate once again the entire limb. The part position, the knee is extended and the limb is medially rotated, again 45 degrees. Remember, it's not just a turn of the foot, it's an actual rotation of the entire limb itself. And then you're going to collimate down to about a 10 by 12. For the central ray, once again, it would be dependent on the measurement from the ASIS to tabletop. Less than 19 centimeters, 3 to 5 degrees caudad, 19 to 24 centimeters perpendicular, and greater than 24 centimeters, 3 to 5 degrees cephalad. And once again, you're entering 1/2 inch below the patellar apex. So notice on the medial, you're separating the tibia from the fibula. On the lateral rotation, there was actually superimposition. We'll take a look at that again when we get to the criteria and evaluating the images at the end of this presentation. And once again, you're going to collimate to a 10 by 12. We'll move on to the essential projections for the intercondylar fossa. According to Merrill's, there are 2 essential projections. These are going to be either the Holmblad method, which is a PA axial, or the Camp-Coventry method, which is also a PA axial. There is an additional method that's talked about in Merrill's. It's called the Beclere or Beclere method. For any of these, you're going to collimate your field to about an 8 by 10. We'll talk first about the PA axial, the Holmblad. You can see that there's variations on how you can perform this method. You have to evaluate the patient's ability to safely be placed in one of the 3 positions. It's either standing with the affected knee flexed and resting on a stool, as in the top picture, standing beside the table with the affected knee flexed and in contact with the IR, the middle picture, and or kneeling on the table with the affected knee over the IR. Whichever of those you choose to do, okay, you're going to take a look at this diagram here. Take a look at the femur to the IR, that angle. Then take a look at your central ray. It's coming down perpendicular. So for part position, anterior surface of the knee will be on the IR. The apex of the patella is centered to the IR. And the knee is flexed 70 degrees from full extension. So take a look once again at the angle of the femur And notice that that angle of the femur to the IR, to the plane of the IR, is 70 degrees. Central ray then will be perpendicular to the tibia and the fibula, and you're entering the midpoint of the IR. We call these views tunnel views, and you can see why. If you look at the radiograph there, it almost looks like a little tunnel right through the condyles of the femur. Another one you might choose to do would be the Camp-Coventry method. In this one, the patient is going to be prone. The knee is either flexed 40 degrees or 50 degrees. It's going to be resting on a sponge. You can see that. Sometimes if you don't have a sponge, you can be creative, different things to build up the leg, but it has to be built up to either 40 or 50 degrees. The foot is resting on whatever support you choose, and there's no rotation of the leg. Notice the central ray. It's going to be coming down in a caudal direction. So central ray perpendicular to long axis of the lower leg, centered to the knee joint. And the angle is going to depend on the knee amount of knee flexion. 40 degrees caudal when the knee is flexed 40 degrees, or 50 degrees caudal when the knee is flexed 50 degrees. So either 40, 40, or 50, 50. The Beclere method or Beclere method is not an essential projection. I bring it to your attention though. Sometimes you see questions about this in review books. It's an AP axial projection, so the patient is supine with the leg bent enough to place the long axis of the femur at an angle of 60 degrees. So this has got a 60-degree bend here to the long axis of the tibia. And then your central ray, notice it's going to be coming in perpendicular to the long axis of the lower leg, entering the knee joint. So look at the axis of the lower leg, look at your central ray, you're coming down perpendicular to that lower leg, and you're going right through the knee joint, also giving you a nice tunnel view. Let's move on to the patella now. So we've got essential projections for the patella being the PA, the lateral of the patella. It's a medial lateral. And the essential projection as far as tangential is the Settegast method. There are additional methods. This would be the Hughston and the Merchant, which we'll talk about. So first of all, the PA patella. Patient is prone, part position, center the IR to the patella. Adjust the limb to place the patella parallel with the IR. And notice what it says here, usually requires a 5 to 10 degree lateral rotation of the heel. You're trying to get a perfect PA of the patella. The central ray is going to be perpendicular to the mid-popliteal area. Remember, your popliteal area is the back of your knee. You're going to be exiting the patella. And notice a smaller collimated field, 6 by 6 inches. You don't need the entire amount of distal femur and proximal lower leg that you would for a typical PA or AP of the knee. For the lateral of the patella, lateral recumbent on the affected side. Flex the unaffected limb and place it in front of the affected limb for stability. Take a look at the picture there. Notice the difference here in the amount that you're going to bend the knee. Remember, for the lateral of the knee, you bent more than this 5 to 10 degrees for the patella. The knee is in a lateral position, and the patella is perpendicular to the IR. Here is a radiograph of a lateral of the patella. Notice looks like they clipped off some of the condyles there of the femur, but that's okay because you're only looking at the patella here. So your central ray is perpendicular to the IR. You're entering the knee at the mid-patellofemoral joint. And small little field here, 4 by 4. As far as the tangential projection, well, first of all, we have to remember what tangential means. Tangential means to do what? That's right, to skim, right? We're going to skim the part. The There is a note in Merrill's. It says you want to rule out any transverse fracture of the patella before attempting this projection. Patient position can be supine or prone can be used. So if we look at the picture here, we have the leg. It's in a bent position. So slowly flex the knee as much as possible or until the patella is perpendicular to the IR. You adjust the knee to place the long axis vertical, and you center the IR to the joint space. Central ray is perpendicular to the joint space when the joint is perpendicular to the IR. Your central ray angle required when the space is not perpendicular to the IR. The angle will depend on the amount of knee flexion. So typically it's about a 15 to 20 degree cephalad angulation. The collimated feel, single 4x4. You just want to get that nice little patella kind of floating on the condyles, or bilateral 4x10. Most sites probably that you've been at probably use the method at the bottom picture there. However, there you can do the way that it's pictured also in the top photograph as well. Here are the way that the patella should look. Okay, you can see it. It's almost like it's just like floating on the condyles there. Sometimes texts call this a mountain view or a sunrise or a skyline view. So there's many different names for this. Kind of interesting, the top radiographs there in B, there's a little fracture there through that patella. Down at the bottom, that radiograph is with the knees done bilaterally. The Hughston method is another method that can be used. The IR is under the femoral portion of the knee. In this instance, the affected knee is flexed, so the lower leg forms a 50 to 60 degree angle from the IR. Interesting, I want you to look at this. The foot is resting on the collimator. It's not something I would suggest, from being in clinical. The collimator gets hot, and also anytime you're going to take an x-ray, you don't want to have the patient in contact with the x-ray tube or the collimator. In the unlikely event that there would be a short, the patient could be shocked. So probably not a good idea to rest it on the collimator. Central ray is angled 45 degrees cephalad and directed through the patellofemoral joint space. There's the radiograph that you would get over on the right. Another way to do a tangential of the patellae would be the merchant method. This is an interesting one. You've got a 6-foot SID, and that's going to be used because you need to compensate for this very large OID. Take a look at where the image receptor is. Take a look where the knees are. Look at that big OID. Remember, when you've got a big OID, the only way to compensate is to increase your SID. So for this one, it's an axial viewer device like is shown is needed. You can be creative. You can use a chair at the end of the table. I've seen that. And then you put some pillows and put the feet resting on that. You can be a little bit creative, but in Merrill's it recommends that you have this axial viewer. Patient's going to slide to the end of the table. Angle of knee flexion is adjusted to about 40 degrees. Central ray is perpendicular to the IR, angled 30 degrees caudal from the horizontal. So you're going to be angling down about 30 degrees. And this bilateral image shows an axial projection of the patellae and then the patellofemoral joint. So once again, it's almost like the patellae are kind of floating on top of the condyles. Let's move on to essential projections then for the femur. There are basically two. There's the AP and then there is the lateral of the femur. Collimated field for both projections, 1 inch on the sides of the shadow of the femur and 17 inches in length. Oftentimes you're going to have to do 2 projections for the AP femur, one knee up and the other hip down. For these projections, however, the patient is supine. There's no rotation of the pelvis. Part position to include the knee, the leg is extended, affected thigh is centered to the midline of the IR. Notice what it says, limb internally rotated. So you're going to rotate that limb internally to place the femoral epicondyles parallel with the IR. So you imagine a plane passing through the condyles or epicondyles, you want that to be parallel with the IR. So that usually requires a little bit of internal rotation. And then notice the bottom of your IR is about 2 inches below the knee. Well, if you're going to do that, you're probably going to clip the hip joint unless you have a younger person. Notice on the radiograph, you've got the knee joint, you've got the mid to distal femur, but you have clipped the proximal. So you're going to have to do one then to include the hip area so that once again the leg remains extended, affected thigh is centered to the midline of the IR. In this case now you're going to take the top of your IR, your 14 by 17, and you're going to put the top of the IR at the level of the ASIS. Remember that's that very palpable bony landmark of the pelvis, the ASIS. And once again, limb rotated internally 10 to 15 degrees to place the femoral necks in profile. The femoral necks go back at a little bit of an angle, so if we internally rotate the feet, that's going to bring the necks of the femur parallel with the image receptor, and you will not or should not have foreshortening then of the femoral necks. Central ray will be perpendicular to the center of the IR. For the lateral of the femur, patient position, turn toward the affected side, so they're going to lay on their affected side, center the affected thigh to the midline of the grid. And once again, since it's a long bone that you're probably not going to get on one 14 by 17, we're going to have to do 2 projections here. So part position to include the knee. Place the unaffected limb in front of the affected limb for support. So take a look at the picture. We're going to adjust the pelvis into a true lateral position. Flex the affected knee about 45 degrees. And then we're going to place the epicondyles perpendicular to the tabletop. Or the lateral of the femur to include the hip. I just want to point out that at many places, instead of this projection, they'll do what techs call the frog lateral of the hip. However, we'll cover that when we cover our next unit with hip and pelvis. Right now, let's go over it the way it is presented in Merrill's, the lateral for the proximal femur. This one's a little bit tricky. You're going to start your patient in a lateral position, meaning the pelvis is going to be lateral. And then what we're going to have to do is we're going to try and keep the leg on the table, the femur on the table, and we're going to try and tilt the pelvis back just a little bit, about 10 to 15 degrees. So it's a little bit tricky. So according to the slide here, draw the unaffected limb posterior now. So we're going to bring that leg posteriorly, the unaffected, and we're going to tilt that pelvis back about 10 to 15 degrees from the true lateral. Central ray is going to be perpendicular to the midpoint of the IR. Okay, so you can see then the image that you would get would be on the right-hand side. Let's take a look at some of the images and that goes along with them. So for the AP oblique knee position with lateral rotation, evidence of proper collimation, medial femoral and tibial condyles are seen. You can see the tibial plateaus. Very, very important. The fibula is superimposed over the lateral half of the tibia. Take a look at the radiograph. Look at the fibula. Notice it's over the lateral half of the tibia. Notice the margin of the patella projected slightly beyond the edge of the lateral femoral condyle. The knee joint, it should be open, and you should see soft tissue and bony trabecular detail. So what's most important here is that for the lateral rotation, we're going to superimpose the tibia and the fibula. Let's move on to the medial oblique of the knee, AP. Now we can see separation of the tibia and the fibula. So once again, we want to demonstrate proper collimation, tibia and fibula separated at their proximal articulation. We see the posterior tibia, lateral condyles of the femur and the tibia are seen. Both tibial plateaus, the margin of the patella projecting slightly beyond the medial side of the femoral condyle now. Open knee joint, and then soft tissue and bony trabeculation again. So with the lateral oblique, we superimpose the tibia and the fibula, and with the medial oblique, we open up that joint space, that proximal tibiofibular joint space. For the PA axial intercondylar fossa, the Holmblad method, open intercondylar fossa. Once again, you can see like that tunnel right through the condyles. Posterior inferior surface of the femoral condyles are seen. The knee joint space is open with one or both tibial plateaus in profile. Apex of the patella is not superimposing the fossa. There is no rotation demonstrated by slight tibiofibular overlap and centered intercondylar eminence. And we want to see soft tissue and bony trabecular detail. For the Camp-Coventry method, also one of your tunnel views, once again, evidence of proper collimation, open intercondylar fossa, posterior inferior surfaces of the femoral condyles are seen. The knee joint space is open with one or both tibial plateaus in profile. Apex of patella, once again, is not superimposing the fossa. There's no rotation. You're going to see that by demonstrating a slight tibiofibular overlap and centered intercondylar eminence. And then we want to see soft tissue and bony trabecular detail. For a PA of the patella, evidence of proper collimation. The patella is completely superimposed by the femur. There is no rotation. Adequate brightness and contrast for clear visualization of the patella through the superimposing femur. And we want to see soft tissue and bony trabecular detail. Arrows pointing to a fracture through this patella here. For the lateral of the patella, evidence of proper collimation again. Knee is flexed only 5 to 10 degrees versus that 20 to 30 for the lateral of the knee. Patella is in lateral profile. Open patellofemoral joint space. Soft tissue and bony trabecular detail are seen. For the Settegast, the tangential for the patella, evidence of proper collimation. Patella is in profile. Femoral condyles and the intercondylar sulcus are seen. Very important, open patellofemoral articulation. It almost looks like that patella is kind of just like floating on top of those condyles there, giving you that mountain kind of presentation. Soft tissue and bony trabecular detail are seen. For the AP of the femur, evidence of proper collimation. Most of the femur and the joint nearest to the pathologic condition or site of injury, a second projection of the other joint is recommended. In fact, it's a long bone. You should always have both joints. Femoral neck is not foreshortened on the proximal femur. Why? Because remember, you internally rotated the leg. Lesser trochanter not seen. Look at the lesser trochanter. Lesser trochanter not seen beyond the medial border of the femur, or only a small, very small portion seen on the proximal femur, as in this radiograph here. Just a small portion is seen. No knee rotation on the distal femur. Gonad shielding when indicated, but without the shield covering the proximal femur. Any orthopedic appliance, meaning a pin, for example, in its entirety, and soft tissue and bony trabecular detail must be seen. So for the AP, remember you're going to do AP proximal, hip down, AP distal, knee up. For the lateral of the femur, the distal, evidence of proper collimation. Most of the femur and joint nearest pathologic condition or site of injury. Once again, a second radiograph of the other end of the femur is recommended. Once again, it's a long bone. You should have both joints. Any orthopedic appliance in its entirety. Soft tissue and bony trabecular detail should be seen. With the knee included, as in this radiograph, superimposed anterior surface of the femoral condyles. Patella should be in profile. You have that open patellofemoral space. Inferior surface of the femoral condyles not superimposed. Why? Because remember, you're centering to the middle of your image receptor and you're catching those condyles with your divergent rays of your beam, which is then not allowing them to be superimposed. So if you look at the lateral distal femur, you're going to see that those condyles will not be superimposed. For the lateral femur, the hip area, opposite thigh is not over the proximal femur and hip joint. The greater trochanter is superimposed over the distal femoral neck, and the lesser trochanter is visible on the medial aspect of the proximal femur. Let's take a look at some projections now to see if you are able to determine which projection the radiograph is showing. So this first one here are your choices. So for this one, you should have picked the lateral of the distal femur, B. Take a look at the next one. Look at your choices. So for this one, you should have guessed the AP oblique. Now look at the tibia and the fibula. They're superimposed, so that's going to be your lateral rotation. Lateral rotation. Let's look at the next one here. Take a look at your choices. This one should be C. This is the lateral of the proximal femur. Look at this one. Look at your choices. Hopefully you guessed B, the tangential patella, the Settegast method. Look at this one. Take a look at your choices. This one would be B, lateral of the patella. Take a look at this one. Look at your choices. This would be an AP of the proximal femur, so B is your choice here. Take a look at this one. Look at the choices. Hopefully you guessed that this was a PA axial for the intercondylar fossa. You can see that tunnel there, so C is the answer. Take a look at the names here of the methods. Hopefully you guessed the correct one, which is D, the Camp-Coventry. Take a look at this radiograph. Let's look at your choices. And hopefully you guessed it was D, the PA of the patella. Take a look at this one. Look at your choices. Hopefully you guessed correctly. C, an AP of the knee. Take a look at this one. Here we've got two of the lower extremity on the same image. So hopefully you guessed it was A, bilateral, knees upright. Take a look at this one. Now notice what's happening here. You're separating the tibia from the fibula. So look at your choices. So this would be C. This is an AP oblique with medial rotation. Take a look at this one. Get your choices. And hopefully you guessed that it is D, the PA axial for the intercondylar fossa. Once again, another of your tunnel views.